I don't know a lot about cricket, but what I do know is that Sam Billings just dislocated his left shoulder in a cricket match. Was it in a cricket match?
I don't know.
I think it was in a cricket match.
Yeah.
Yeah, it was in a game. Kind of like baseball. But the batting is different, and they have this thing called the wicket.
Wicket, wicket.
I may not know a lot about cricket, but I know a lot about shoulders. So let's talk about shoulders. We want to zoom right in. This is the body. There's Sam. Obviously, he doesn't have any skin or anything like that. And what we want to do is try and identify what is actually going on in the shoulder. And so we're going to zoom in right here in the shoulder. And when we look inside the shoulder, all the muscles and all the bones are removed. You can see that the chest wall is over here. And you can see that this is coming all the way down here. And looking around at different angles, this is looking at the back of the shoulder from here. Then I move it over here, I'm looking at the top. But we're really trying to understand what exactly is going on with the shoulder. Okay. And what I'd like to show you here is, remember the biceps tendon? That was coming right along here, through here, okay? There's the glenoid articular surface. And there, right here, is the humeral head, and there's the shaft, okay? So now that we've got our shoulder capsular joint model, you see that we have various ligaments with the shoulder: the superior glenohumeral ligament, middle glenohumeral ligament, inferior glenohumeral ligament. They are all part of the anteroinferior capsule. And in a shoulder dislocation, now, first of all, we don't know whether it was posterior or anterior. More common dislocations happen anterior. So that means going out the front of the shoulder. So what happens? Most of the times it's the inferior glenohumeral ligament that gets affected, and it dislocates. And when it does that, it then affects the overall joint structure and stability. Now, if we were to rotate this, let's look at this from above, okay? So when we look at it from above, and we drop down, this is going anterior. So chest wall, you can see, is right there. This is the back. So when we have a shoulder dislocation, this humeral head, I'm going to draw it out here, okay, goes out the front, okay? But this area in this section, and I'm just going to get it into view and put my pen on again, you can see it's this part of the glenohumeral joint that really gets affected, of the glenoid, okay? And you get a dislocation, you tear the ligaments, and based on age and a lot of factors, mostly age, the risk of a redislocation is higher when you're younger, and most of the time for young athletes, you're gonna have a repair. Most do an arthroscopic anterior Bankart repair, where you essentially repair the ligaments in the anterior inferior capsule. Depends. Sometimes the tear could go circumferentially, so it could affect the entire circumference, including the quality of the anchor to the biceps. So you could disrupt the biceps, you could disrupt all the ligaments down here, and even along the back, depending on the type of ligament injury. So now we're going to go back to the model, and then what I want to show you is that the labrum, so this right here is the labrum, okay? And that goes circumferentially around, and it's the labrum that gets torn off, and that's why it's called a Bankart repair, Bankart labral repair. Now, historically it was called a Bankart repair. That was when it was done open. Now we do it arthroscopically, and now it's an anterior repair, labral repair, capsular shift, all of those factors, and you may not necessarily hear the term or the name Bankart associated with the shoulder repair for an anterior dislocation. Now, if it's a posterior dislocation, it's posterior Bankart. Sometimes you see that. So there's a lot of features involved, but that's a labrum. It's a bumper that's on top of it. So I'm going to show you in the model here. You take the subscapularis out of the way. You see the glenohumeral joint. So there it's all rotating, okay? there's the labrum, which is a little bumper right on top of the socket, which is the bone. Obviously the capsule is removed over here, and it's that labrum which you try and repair. I'll show you that now. So if you take the glenoid, which is the socket over there, and you're turning it around, so if you're looking at it from the face, so that means I'm actually looking at it from this angle, okay? So that's the face. And if I were to look at it in that plane, then you say this is the 12 o'clock position. This, on that face, is the 3 o'clock position, okay? And that is the 9 o'clock position. So if we go back to our shoulder, that we know is the 12 o'clock position. And so we basically make a clock face. So there's 12, okay? There's 3, and there's 9. And obviously down here is 6. So if we look at that, what we're doing is that the labrum is damaged. And if the labrum is damaged, that means that the bumper that's lining the labrum all around here, the bumper all along the edge, and it goes all the way around circumferentially. I'm just showing for purposes of traditional dislocations. Usually it's the damage of the anterior inferior ligaments for an anterior dislocation. And that labrum also gets detached, okay, with the capsule. Now, if that happens, we know that's bone. We are basically creating little drill holes, drill holes, drill holes, and sometimes all the way down, you know, to the inferior section over here. And we actually capture the tissue, and we basically are putting knots and reconstructing it back. So it's essentially a tie-down technique. Labrum's off, we put a bolt in the bone, we bring essentially rope, it's tiny rope, through the tissue, and on the socket, cinch it back down. Now, this is just sitting on a little tiny piece of bone called the glenoid. Imagine the amount, look how unstable that is, look. I mean, that's about the size of your glenoid on that big joint, and if I move it, it can fall off. So that's the risk. So what happens after the glenoid is repaired? So you got the suture anchors, you got the repair, boom, you're done, you're onto your recovery phase, and the mental game. Don't forget the mind. So you're rehabbing, you're recovering, the tissue has to heal the bone. So the pathophysiology, the biology, the physiology of healing is such that you need the 6 to 8 weeks. So the important part is you want the fresh tissue, torn tissue, then heal onto bone. That takes anywhere from 6 to 8 weeks to heal, but you don't want to get stiff by leaving them closed next to their shoulder like that. In fact, we used to put patients in a cast, in a shoulder body cast after a repair reconstruction in the past. We don't do that anymore. We get them in a shoulder immobilizer, but we get them moving, gentle motion early, just light pendulum, and then we gradually start increasing their motion. And then after 3 months, we might increase the dynamics of the motion, and then we start really pushing the strengthening. So 6 months is typically when they're going to return, starting to do some type of throwing, pitching, non-performance, probably in the neighborhood of 50 to 70, maybe 80% of effort, and in a professional player, it would probably be still quite low in terms of speed. Once you hit somewhere after 6 months, between 6 and 12 months, depending on the healing, recovery, rehab, and strength and overall kinematic balance, you may increase it to try and push towards that 100%. And of course, you could have any type of regenerative technology included with any of those, and more often than not, every facility has a different relative protocol, but in general, that's kind of what we're looking at as a semblance of healing and recovery on a conservative perspective. But all in all, if they got injured in 1 year, they're going to be returning or not likely to return until the following year. And that could span several months to a year for their full recovery until they're up to their full speed. Whether they're doing a baseball or whether they're doing a pitching or whether they're a swimmer or other athlete. So Sam Billings, I hope you make the cricket matches next year. And I hope you have a great recovery. Good luck with your shoulder.
I got bones.